Welcome back. To round out our afternoon session, we will have presentations from our two final speakers, followed by time for questions. So I'll ask you now to think about what questions you would like to send in by text so that you're ready when we start our question period. And the number will be up on the screen for you when we get to that stage in the afternoon. Our first speaker is Katy Windl. Katy is a Métis pharmacist. She graduated from the U of S College of Pharmacy and Nutrition in 2010. Katy served in the Canadian Armed Forces for 15 years. During her military career, she completed a military pharmacy residency program through the Vancouver Island Health Authority in Victoria, British Columbia, and became a supporting pharmacist for Canada's Pacific Naval Fleet. Later in 2014, she was posted to an Army base in Manitoba, where she expanded her practice in mental health and addictions. In 2016, Katy retired from the military and joined First Nations and Inuit Health under the non-insured health benefits umbrella as Saskatchewan's regional pharmacist. Katy will be presenting on the topic of diabetes medications and non-insured health benefits. Our last speaker today is Faye Evans. Faye is a chronic disease clinical nurse specialist for Indigenous Services Canada. Faye holds a Master of Science in Nursing from Hawaii Pacific University, where she was a family nurse practitioner. Her extensive nursing experience also includes several years in acute and community health in the areas of frontline nursing management and clinical utilization. Faye has worked with Dr. Hugh Tildesley at Providence St. Paul's Hospital in Vancouver in clinical research in diabetes and other endocrine disorders. Having lived and worked in Montreal, Vancouver, Hawaii, and Seoul, South Korea, Faye has learned from and relates respectfully with people of her own and other cultures and is continuing to learn from culturally supported best practices in healthcare. Our first speaker, as I mentioned, is Katy Windl. Katy?
Thank you, Kathy. It's a pleasure to be here today. Thank you for having me. And thank you for allowing me to come to Treaty 6 territory, and that's what I want to start with today is the acknowledgement of the territory that we're on, and really go into this quote about reconciliation from the Treaty Commission. And its reconciliation efforts are not one-sided. It must grow from people together. Reconciliation is about learning the past and choosing to build a better future. It's understanding each other, and it's building trust. And so this is just a good way to start that reconciliation process as we go through in the next little while and in your daily practice, keeping that in mind. I have no disclosures or affiliations with pharmaceuticals or medical devices. Basically, what I'd like to cover today is what are non-insured health benefits? A lot of people don't know what that is. How do medications get added to that formulary that non-insured has? And based off of that, we come on to the CADETH recommendations around type 2 diabetes medications. And then lastly, I'll finish with non-insured health benefits coverage of the diabetes medications and supplies. Before I start, I just want to give you a little bit of background of what my role is here in Saskatchewan. I'm the senior pharmacy specialist in the region, which really means I'm the liaison for non-insured and provincial organizations and provincial basically anyone in the province is my job to liaise with them. I provide guidance around the policies that we have. I provide evidence-based direction to our policies and our programs within FNIB or First Nations Inuit Health. A lot of my work right now is around education on appropriate drug use. So I do specialize more so in mental health and addictions in that area. And when I'm lucky enough to be asked to go into First Nations and provide guidance, I'm very humbled by that as well. So what are non-insured health benefits? Non-insured health benefits are those that are for First Nations and Inuit. and they're beyond what is covered by the Canada Health Act, so beyond what is provided by the provinces or third-party plans. In Saskatchewan, we have served around 150,000 First Nations people, and this is on and off reserve, so non-insured is not only for people who live on reserve, but it's for everyone with First Nations or Inuit status. The principles around non-insured health benefits, really what we try to do with this program is to make sure it's consistent throughout the country, but still be able to respond to that specific need in the region. These items have to be medically necessary. We try to be most economical with nearest provider, and no extra billing on top of what is billed, especially like it's the drug and the dispensing fee. And then portable across provinces. Non-insured has 6 different benefit areas. Pharmacy is the one where I deal with, and I have colleagues who support the medical supplies and equipment area. Dental is based out of Ottawa. Vision is here in the region. Mental health counseling is also available. And lastly, medical transportation. And all of those benefits are under non-insured health benefits. So I'm going to zone in a little bit around pharmacy benefits or drug benefits. So the basis of these is that they have to be prescribed by a regulated health professional. And the only exception to this is pharmacists prescribing over-the-counter medications. And now, thank goodness, we have something called pharmacist-initiated treatments, and I'll talk a little bit about that in the next couple slides. Sometimes there's eligibility requirements for different benefits, and then there shouldn't be any direct cost to the patient. And so all of those costs, if a patient takes the prescription into the pharmacy, they should not be billed for anything beyond that prescription. So if you're ever wondering what is part of that benefit list, if you're thinking, oh, what is that drug covered? We do have an online version of what is covered, and it's called the Drug Benefit List. So DBL for short, if you've ever heard of that. And you can Google this and you'll find this come up, and you can see if these drugs are covered under non-insured. There are also some other special formularies for renal failure patients, for palliative care patients, and a new one that was just recently added, and it's for medications for people who are undergoing active chemotherapy. Overall, in our program, we have 3 types of benefits. And so if you ever call into Drug Exception Center, they might talk about these. And just to go through this so you have an understanding of some of the jargon that we use. The first one is the open benefit. So open benefits are pharmacy prescription drugs that don't have any really they don't have any limits or any special circumstances in which they need to be prescribed. So metformin would be one of those. You don't have to meet a certain criteria to be able to prescribe it. And so we have a lot of open benefits, and that's what you're going to find in the formulary. The second one that we have is called a limited benefit, and sometimes people might refer to these as an LU. These are medications that have value in certain circumstances, or they have like a time limit to them. So some antibiotics are in that list. Nicotine replacement for smoking cessation, we have some of those limits as well. And then we have exceptions. So these are drugs that this is where the pharmacist will call in to Ottawa. It's not to me. I'm not the person who approves the drugs for people through non-insured. This is where the pharmacy is going to call in and get a prior approval for this medication. So exception drugs are not on that benefit list that I talked about earlier. They're not on a formulary. So if there are drugs that you want to look at for a patient and they're not on that formulary, most likely they would fall under exception. We do have a few things that are actually a complete exclusion as well. I don't have that on here. Those are things like vaccines are an exclusion under our program. Moving on, like I said, pharmacists, we do have what's called pharmacist-initiated treatment now. And so this is one of the older, this picture in here is actually one of the older ones. This is what we first started covering under pharmacist-initiated treatment. And so these are medications and diabetes supplies that pharmacists don't require a prescription for, as they could recommend it themselves and bill non-insured for it. This is online, and that's the best version that you would get to make sure it's the most up-to-date version as well. One thing to note is we do have a process for patients to appeal a drug decision by drug exception center. So if there is a need, a medical requirement for a patient to, get a drug covered, and it was denied by Drug Exception Center out of Ottawa, patients can appeal that decision, and they can appeal it actually up to 3 times. And so every time that they do an appeal, it goes up to a further level within our organization. And so keeping that in mind, there are certain things that they will look at under an appeal process. And if people need help with that, they could always contact me. A lot of what I do here in the region is really advocating for patients and for our healthcare professionals. Our program is really in this revolution right now, and so that's something else I want to identify is our program has been really changing, and new things are being added, and we're really excited about some changes that we've undergone. One of the newest ones that probably all the healthcare professionals are going to really like is that patients can now call Drug Exception Center on their own behalf. So previously, it was only pharmacists could call, no one else could call, and now they've opened this line up, and so you can see the 1-800 number on your screen. If patients want to get some information about where they are in the process to get something approved, they can call in themselves and get that information. Secondly, as you probably are aware, we're no longer under Health Canada, as our organization has changed to Indigenous Services Canada, and so we are seeing a lot of changes with that as well. Something to keep in mind is if you have a lot of patients that have non-insured health benefits, you can sign up for our updates. So our program is updated usually on a quarterly basis. If you go online, there's actually a spot where you could click and become part of a mailing address to let you know when changes have recently come up in our program. And I'm going to mention a couple of them, a couple of the drug changes recently that we've had as well, and that's going to be part of our next update coming out this December. I have had healthcare professionals say, you know what, this is part of what we actually start using in our team meetings on a quarterly basis because it's so helpful to help our patients to navigate that program. Moving on into how do medications get added to our formulary? I do get this quite a bit, and I have a lot of healthcare providers saying, well, how do we get this added, Katy? And so there is a process, and some people might actually be even familiar with that process. It's actually through CADTH's Common Drug Review is where it starts. So if you take a look at this slide, on the right-hand side, we have basically a flow chart. If you start at the top, what it is the companies design their new drug, they go down, they get safety approval through Health Canada. And then if you keep going south on that, it talks about, okay, so after it's approved, it's safe, CADTH takes a look and says, well, is this really an effective treatment that's worth our cost as well? And if it is, then what happens is that drug will go to something else called the Pan-Canadian Pharmaceutical Alliance. And I'll talk about both of those a little bit more in depth. So CADTH is an independent, non-profit organization that's really there to provide objective evidence. And there's and provide those decisions about what really is good optimal use of health technologies. They look for experts, and these experts are from across Canada, and they provide their input. We have some doctors here at this university that are part of this CADITH organization. So once CADITH says, yes, you know what, this would be a benefit, what happens is this drug then is looked at by something called the Pan-Canadian Pharmaceutical Alliance. This is new. It hasn't been around for too terribly long. But what it does is it really harnesses all of these people from across Canada, all the provinces and these federal organizations to really achieve a greater value for these publicly funded drug programs. So they take a look at these brand names, and then they go back to the manufacturers and say, what kind of price can you give us if we are having provinces across the country purchase them? So this is a joint approach that's really leveraging some of that purchasing power. This is older data, but as of March 31st in 2017, they actually saved Canada probably around $1.28 billion just in these negotiations themselves. So that's how it's done, but let's look particularly at why do we see this kind of disjointed recommendation sometimes when we take a look at this. Specifically, we do have some recommendations that are different than what we have seen in the guidelines. So CADITH has done a second-line therapy review for type 2 diabetes, and it's actually a fairly good article, so I'd recommend you going in and taking a look at that. And in particular, for type 2 diabetes, they went and they came up with these specific recommendations, saying that all of the drugs that they reviewed worked well in treating diabetes, in that they all similarly reduced A1C. And we've talked about that pretty much most of the day today when they're added to metformin. So this is, what do you do after you've added metformin? What do you add next? So CADITH's recommendation was that. And the drugs that provide the best value for money when they take a look at all of these things was actually sulfonylureas. And we're going to talk just a little bit about their data that they came up with. I was actually, Debbie Bunka from CADITH has allowed me to use her slides, and I'm very thankful for that. And so I'll take you through why did they come up with that recommendation? So there are those newer clinical trials that are showing that certain drugs do help to protect patients with type 2 diabetes with established cardiovascular disease. But the CADITH says that at this time they really don't have enough evidence to make a real drug class recommendation versus a specific drug recommendation. So the committee has remained supportive of that individual drug recommendation for empagliflozin, to reduce the incidences of cardiovascular disease. So I'll just walk you through some of these recommendations. So for adults with type 2 diabetes, CADITH is recommended without established cardiovascular disease to add a SU drug to metformin once metformin, diet, and exercise are not enough to control blood glucose levels. So how did they come up with that recommendation is the key question. So what they did is, their research question is they went back to what's out there for evidence, and they said, what is that comparative efficacy and safety of using the drugs from these following classes? So they took a look at SUs, they took a look at insulins, DPP4s, GLP-1s, and SGLT2s in this research. And they got a whole bunch of different types of input even. They got some patient input, they looked at systematic reviews, they got some clinical expertise and stakeholder feedback. So when they looked at this, they did take a look at about 175 RCTs, which is quite a bit. 66 or 166, excuse me, reported outcomes of interest. Evidence was available, just like I said, for those medications that we just talked about. And there wasn't any studies that they found a bolus insulin reported for outcomes. So when you look at the results, it's similar to what Dr. Dawson has already said earlier today, is taking a look at what is the actual A1C reduction. And you can see, they differ from 0.7 to 0.8 or 0.9 or 1% of A1C reduction for the main part of these medications. They also did take into account, this is a huge part as well, is we do have to take a look at the patient as a whole. What about the body weight? And so there was weight gain associated with sulfonylureas and basal insulin, weight neutral for DPP4s, and some weight loss for SGL2s and GLP1s. They also took into consideration the rates of severe or hypoglycemia. So severe hypoglycemia, we do know that sulfonylureas are one of the main culprits. And then you could see a little bit less in this particular, in the 48 RCTs that they took a look at, was insulins, GLP-1s, and then SGL2 inhibitors. This is a slide that has really intrigued me from the first time I saw this presented from Katy. And it just gives you that visual representation. We talk a lot of times about, well, what is that risk of hypoglycemia? And it's about 1 in 175 patients. And so this really just gives you that visual to see what we're talking about when we talk about that risk. So it just helps to understand that a little bit better. For non-severe hypoglycemia, we see the SUs and the insulin are the main culprits there, the biphasic insulin versus the basal, and then the SGL2 and GLP-1s. So when they took a look at this, trying to figure out, well, what should we add after metformin becomes insufficient for treating diabetes, they said the sulfonylureas are definitely the most cost-effective second-line therapy. And they even did a threshold analysis that indicated, that the costs of those DPP4s, the GLP-1s, and the SGL2 inhibitors would require a really significant decrease in price to surpass the effectiveness of sulfonylureas. They even took into consideration the quality of life adjustments for weight gain. They took into consideration, that price adjusting for SUs, analysis for more expensive agents if they were to decrease those prices. And whatnot. So it was quite interesting when I first saw this data. It really opened my eyes a little bit. So when we look at the 2018 CBGs, really that second line agent should be made based on that individual patient characteristics. So that patient might have certain preferences. Are there any contraindications like allergies or something like that? And one thing to note on this is also the affordability and access, as well as the body weight and other factors. So patients might prefer a DPP4 inhibitor or GLP-1 receptor agonist to other agents. And if there are no contraindications and really affordability and access isn't a barrier, they could be an option. There was another article out of the Pharmacists Letter of Canada, which was really good article as well, so I would recommend, if you have access to that, to check it out. The second message that came out was for, what about adults with type 2 diabetes that do have the established cardiovascular disease? And so they took a look at that recommendation via an individual kind of drug review for this indication. And so when CADTH looked at this, they came up with the recommendation to reimburse that empagliflozin for patients with type 2 diabetes as a second-line therapy after metformin that do have established cardiovascular disease as defined by by the EMPA-REG outcome trials. So there are some individual trials. These are the ones that they really looked more into. And one of the more important ones is, if you've taken a look at the data, is the EMPA-REG outcomes. This is actually a shout out to our local RX files, which is an amazing thing. If you could get your hands on some of them, they really have they have this table in there, and it talks about the EMPA-REG outcomes. So if you wanted to know where empagliflozin was actually shown to be effective in cardiovascular outcomes, this is a really good table to take a look at. So when they looked at that in regards to cardiovascular effects, they looked at these specific drugs: insulin, DPP4 inhibitors, GLP-1 analogs, and SGLT2 inhibitors. They looked at 17 RCTs, and really 11 of them had the outcome of interest. And the evidence was predominantly for those SGLT2 inhibitors, DPP4s, TZDs, and GLP-1 analogs. So the major adverse cardiovascular events, or MACE, in some of these was what they looked at. So they looked at that endpoint of cardiovascular mortality, non-fatal MI, non-fatal stroke, and really out of all of those, the data was really insufficient to conclude that any of the selected drug classes lowered this risk of MACE when compared to placebo or with each other. When they look particularly at mortality reduction, SGLT2 inhibitors reduce the risk of all-cause mortality when compared with placebo or DPP4 inhibitors. Data was insufficient to conclude that any other treatments reduce the risk of all-cause mortality, and none of the selected classes significantly lowered that risk of cardiovascular mortality when compared with placebo or to each other. Hospitalization for heart failure, the data was insufficient here as well to conclude that any of the selected classes significantly lowered the risk of hospitalization for heart failure. Severe hypoglycemia, there was a significant lower risk of severe hypoglycemia, as expected, as we've seen in many of the studies so far with GLP-1 agonists and DPP4 inhibitors. And so in the opinion of CADTH, their expert committee, is really those gaps in evidence really don't show a class effect yet with what we have. And so at this time, they haven't really gone and said, what, this class of drugs is beneficial for cardiovascular health. So this is just a quick outline of what are the recommendations from the CBGs regarding second-line therapy. So if the cardiovascular health is an issue, adding on metformin, and the second line would be empagliflozin. Versus if there is no cardiovascular health risks, adding on a sulfa is what the recommendation is. So all of that information came down. CADTH has made those recommendations. It's gone to the Pan-Canadian Pharmaceutical Alliance for negotiations with the drug companies, is where some of that is at. And some of them have been added to our benefit list. So I'll talk about what is actually part of that benefit list. So non-insured health benefits, these are the oral agents that are covered. There is an addition to this list as well, but this is just one that I've developed, and it talks about all of these are open benefits, meaning there's no need to, one of the questions was, do you always have to start with metformin for getting it covered by drug plans. No, if it's an open benefit, there's no limitations on when that drug could be prescribed. In particular for this one, we do have limited use, meaning yes, you do have to meet certain criteria for TZDs. For non-insured and DPP4 and SGLT2 inhibitors, these are covered as limited use benefits as well. Basically, if that patient has tried and failed metformin and SU, NHB will look to provide coverage for DPP4s and SGLT2 inhibitors. New additions. This is what you would get if you signed up for those updates. Tresiba is now an open benefit as of September. Toujeo is now an open benefit as of October. And Jardiance is also added as a limited use benefit for those with cardiovascular risk. So that is new to our program, and I'm sure people have been asking about Jardiance for years, and so it's very exciting. For insulin, we do have a number of insulins that are covered by the program as well, from the rapid-acting ones to those long-acting ones, the basal insulins, and so there are some choices that prescribers can go through. Insulin pumps are covered under non-insured. So if a patient has type 1 diabetes and the insulin pump is prescribed by an endocrinologist or a specialized prescriber with experience with insulin pumps, they can be covered, and also so are the supplies as well. Test strips. These are just some humorous things I found on the internet. One mosquito to another mosquito, I hope this one is one of those people with diabetes. And the other mosquito says, yeah, some of those are really sweet. We're just in the last few slides now, going over, I really should have updated this one, my apologies over that. But it's just talking about, you know, how often should someone test? And so that is what NIHB has based their coverage on, and most federal drug plans have based their coverage on, is the risk of hypoglycemia and the need to test blood sugars. And so if someone is on insulin, the coverage is 500 strips per 100 days. If they're on medications with high hypoglycemia risk, it's 400 strips per year. And then meds with lower hypoglycemia risk, 200 per year, and then same if they're just changing their or adjusting based on diet and lifestyle. Keep in mind that there are exceptions, and so don't be afraid to ask for these. If you have a patient that requires more strips, they can get approved. They just have to call into Drug Exception Center to see, you know, to get that approval put on their file. So things like pregnancy where they're testing more often, or if they have a job that really is at risk for low blood glucose, should really be avoided, those kinds of things. An acute illness where we should be testing more often. They haven't been meeting their targets, so you know, for the next few months we might want to test more often, starting a new medication, and of course the children that are out there. And if you, we do have other avenues as well, especially for children, now that we have something called Jordan's Principle. So if you are working with a child who needs some different medical needs to be met, we also have the opportunity to approach that through Jordan's Principle. I know, I finished a little bit earlier. My apologies for that, but I'll pass it over to Kathy and see what she has to say.
Thank you very much, Katy, for that very interesting presentation, very scientific presentation. And I'm impressed with how you get around all those words. That's That's quite amazing. One question I had for you, just as we transition to Faye's presentation, is it sounds like there's some really good resources such as updates, recommendations, and prescribing frameworks available for healthcare practitioners and patients. Is there one place where these resources can be accessed?
Yeah, and so there are like the best spot is the website because it's going to be the most up to date as well. So what I recommend instead of giving this big long website is actually go onto Google and Google NIHB
Okay.
formulary or drug benefit list or those kinds of things, and I find you'll find a lot more information. Or NIHB updates will bring you right to the update page where they have all of those things that are changing on a regular basis, because non-insured health benefits is actually teamed up with AFN to develop some changes in our program that are really needed changes. And so our program is rapidly evolving, and we're seeing a lot of changes in the last few years.
So if I get onto that website, will there be links there to CADIF and...
You know what? I don't think there are links
Yeah.
to CADIF. So CADIF would be separate,
Right.
and so would the clinical practice guidelines. Those are separate as well.
Okay, so you will know, and likely a lot of our participants will know as well, that CADIF also provides updates by email if you sign up
Yes.
on all kinds of clinical topics. So you could just Google CADTH.
Right.
And there's a button there you can click on to get those updates as well. And then you would likely get all the updates
Oh,
that
great.
come through.
Yeah, I get those on email.
Right.
Yes.
Yeah.
Yeah.
Okay, thank you very much.